Welcome to the deep dive. Today we are taking on a topic that, well, it surrounds us every single day, but often feels like it's spoken in an entirely different language: pharmacology.
It really does.
For many, this world is just a tangle of complex medical terminology, generic names, chemical actions. It's a lot.
Right.
So we are cutting through that complexity today. We want to understand the foundational principles of how medicine actually works inside the body, inside your body.
And our mission today is really synthesis. We've got this dense stack of sources here, all focused on the nuts and bolts, the definitions, the specific mechanics of drug action.
Right.
And we need to turn that complex lexicon, that language, into immediately digestible and applicable knowledge for you, the listener.
Okay.
But before we even define the first technical term, I think it's important to appreciate the historical philosophy that kind of guides this whole science.
Okay. And to do that, we have to look back. Quite a way back, actually, over 500 years, to the figure often called the grandfather of pharmacology, Paracelsus.
That's right, Paracelsus. He was working way back in the 16th century. And he left us this foundational concept that really, it dictates almost every decision made in modern drug development and patient safety.
Wow. So what wisdom did he leave us that still guides the field today? What did he say?
Well, his quote is, it's really profound.
Yeah.
And it captures the absolute necessity of precision in dosage and preparation. He said, it depends only upon the dose whether a poison is poison or not. A lot kills, a little cures.
That is immediate proof, isn't it? That this science isn't just about identifying some beneficial chemical.
No, not at all.
It's about managing that margin of error between a therapeutic effect and, well, a toxic effect.
Exactly. And that margin, today, we quantify it with concepts like the therapeutic index,
Okay.
which is basically the ratio comparing the dose you need for the desired effect to the dose that causes a toxic or even lethal effect.
So everything we talk about today.
Everything, from the name of a drug to how it's packaged, the specific receptor it targets, it's all aimed at navigating that very narrow space to make sure it cures rather than poisons.
Okay, let's unpack this. What is the difference between simply reading a clinical definition of a drug, from a textbook, and actually understanding the true mechanism of its action once it's inside you, the patient?
That's the core challenge.
That's our challenge today. So we're going to focus on the structure of drug classification, the often overlooked necessity of dosage forms,
Very important. Right?
and the specialized terminology that describes exactly what happens when that carefully prepared substance enters you. We're aiming for fluency here.
Fluency is the goal.
Right. Let's start with the umbrella term then, the core science itself. When we say pharmacology, what specifically are we actually talking about?
Well, pharmacology, broadly defined, is the study of drugs. Simple as that, really. Their origin, their nature, properties, effects, and actions on living organisms. It's the deep dive into the chemical itself. Where did it come from? What does it do? And how does it, elicit an effect?
But knowing the drug is only half the story, right?
That's right. The other crucial half is understanding how your body handles that drug.
And that leads us directly to the concept that governs the timeline of treatment: pharmacokinetics. This is where we start figuring out the lifespan of the medicine in the patient.
Precisely. Pharmacokinetics is sometimes simplified down to what the body does to the drug after it enters.
Okay.
This study focuses on the metabolism and action of drugs, but with a really critical emphasis on the time required for four main processes. People often remember by the acronym ADME.
ADME.
Absorption.
Absorption, distribution, metabolism, and excretion.
Let's dig into those four steps because they really determine everything, don't they? From how often you take a pill to whether the drug even works at all.
They really do. So absorption is how the drug gets into your bloodstream. Is it absorbed through the stomach lining, through the skin, or maybe directly via injection?
Okay, so entry. Entry, yes. Then distribution is where the drug goes once it's circulating. Does it cross the blood-brain barrier, for instance? Does it concentrate in the liver? Or maybe in fat tissue?
So if I see a drug that's prescribed, say, 3 times a day, or one that's marketed as lasting for 24 hours, pharmacokinetics, particularly those last two phases, metabolism and excretion, that's the science explaining why those timelines exist.
Absolutely. Metabolism, which usually happens mainly in the liver, is the process where the body chemically alters the drug. It changes it into forms that are easier to excrete.
Get rid of.
Exactly. And excretion, primarily through the kidneys via urine, is the removal of those altered drugs from the system.
So if my liver breaks down a drug really fast.
Or your kidneys excrete it rapidly, yeah, then you'll need frequent dosing. That's your 3 times a day instruction.
Ah, okay.
But if the distribution is slow, or metabolism is deliberately slowed down somehow by the drug's design.
Like a slow release formulation.
Precisely. Then you get sustained relief, maybe over 24 hours. It dictates the maximum window of effectiveness and how long the drug actually hangs around in your system.
It's the time-based mathematical dance, really.
That's a good way to put it.
Now, before we get into the action, we absolutely have to tackle the confusion just around the names. This is a huge barrier for anyone trying to navigate this field.
Oh, definitely.
We need to differentiate between the generic name and the brand or trade name.
Right. So the generic name, this is the drug name that's usually descriptive of its chemical structure. It's the common scientific identifier. It stays the same no matter who makes it.
And crucially,
it is not protected as a brand or trade name.
So if we're talking about acetaminophen, that's the generic chemical compound.
Correct. Whereas the brand or trade name, that's the proprietary name given by the manufacturer. It's the one you see advertised, like Tylenol.
The marketing name.
It's a marketing asset, yeah. Often designed to be memorable, and it's legally protected by patent, at least while that patent is active.
Okay, what's fascinating here is the inherent regulatory tension, isn't it? The FDA regulates these names to maintain standardization.
They have to.
Because when the patent expires, suddenly multiple companies can make the exact same chemical compound, the same generic drug.
Mm-hmm.
But they'll all sell it under their own new, unique trade names.
That's right.
And if we didn't have that generic name as a constant, non-proprietary chemical anchor, the moment the patent expired, it would be absolute chaos. Trying to track which chemical substance we were actually prescribing or taking would be a massive safety risk.
Huge. It guarantees that regardless of the branding or the cost even, the core chemical structure and the expected action remain the same.
Hmm?
This standardization is just fundamental to patient safety. It lets doctors, pharmacists switch between bioequivalent products with confidence.
So the generic name provides the scientific truth behind the marketing noise.
You could say that, yes.
Okay, moving on from the chemical name to the actual physical form, we're shifting focus now to how the drug is delivered. Section 2, dosage forms and delivery methods. We often overlook this, I think, but the form dictates the route of administration, and that, in turn, often dictates the speed and location of the drug's onset. The physical form is like the engineer's solution to the pharmacokinetic challenge we just talked about.
That's a great way to think about it. The physical form is absolutely critical because it's engineered to survive the journey, basically, to the target site.
Whether that means surviving the stomach acid?
Right, or being absorbed slowly through the skin or whatever the goal is.
So our sources start with the basic classifications by form. We have solids, like the ubiquitous compressed tablet.
The most common form, probably.
And the capsule, which is essentially a soluble shell containing the medicine, often used to mask a bad taste, right? Or to make sure the drug gets past the stomach before dissolving.
Exactly. Or sometimes it contains tiny beads that dissolve at different rates for sustained release.
Ah, clever. Okay, then we move into liquids. A solution is where the drug is dissolved uniformly. So like a simple saline IV or maybe most clear cough syrups.
Yes. The drug is fully dissolved, so it's essentially ready for immediate absorption. The liquid form doesn't require any breakdown step.
Right. The counterpoint to that is the suspension. I think back to when I was a kid, taking those bubble gum flavored antibiotics.
Oh, yeah.
It was always thick, kind of gritty sometimes, and the bottle always said, shake well before using. That's a suspension, isn't it? The drug particles are just dispersed but not actually dissolved.
A perfect, relatable example.
Yeah.
And that shaking is absolutely required because the denser drug particles settle out over time.
Ah.
If you didn't shake it, you'd be getting a really weak dose from the top of the bottle and maybe an overdose from the bottom.
Oh, wow. Okay.
So that difference is a really practical pharmacokinetic consideration. The suspension often allows for high concentrations of drugs that aren't very soluble to still be delivered orally.
Okay. We also have the topical forms, designed for localized application, right, to the skin or mucous membranes, primarily creams and ointments for external use.
Correct, for local effect, usually.
But where it gets really interesting, I think, are the alternative delivery methods, the ones designed to kind of manipulate the timing of the dose.
Exactly. These are often engineered solutions. Consider the transdermal patch.
Like a nicotine patch or pain patches.
Right. This delivers medication directly through the skin into the systemic circulation, into the bloodstream.
Okay.
And it's designed explicitly for slow, steady release over a long period. Days, sometimes. It bypasses that peak and trough effect you get with, say, a pill taken twice a day.
Trying to keep the level constant.
Exactly. Maintain a constant therapeutic concentration.
Then you have the suppository, which is a drug inserted into a body cavity, like the rectum or vagina.
Yeah, this route is often used when the patient can't take oral medication, maybe due to severe vomiting or if the drug is easily destroyed by stomach acids.
Oh.
And interestingly, a rectally administered drug can partially bypass the liver metabolism
Oh, really?
and get into the circulation more directly. That can be a major advantage for some drugs.
And the sources mention the inhalant, a breathable chemical vapor, causing systemic or local effects, like asthma meds
Or general anesthetics, yes. Rapid delivery to the lungs means rapid absorption into the bloodstream for systemic effects, or direct action on the airways for local effects.
And finally, we arrive at probably the fastest, most direct method, parenteral administration.
Right. Defined as any administration that's not through the gastrointestinal tract.
So injections mostly?
Most commonly, yes. Intravenous, right into the vein, intramuscular into the muscle, or subcutaneous, just under the skin.
Why is bypassing the digestive system so, I guess, profoundly important to the therapeutic outcome sometimes?
Well, it bypasses what's called first-pass metabolism.
First-pass metabolism.
Okay,
Yeah.
the liver, which is the primary metabolic organ, receives blood directly from the stomach and intestines through something called the portal vein.
Right.
So if a drug is taken orally, a significant portion of that absorbed drug dose is immediately subjected to intense scrutiny, you could say, by the liver before it even reaches the rest of the body.
So the liver acts as a primary filter, basically, for anything absorbed from the gut.
Precisely. And if a drug is highly susceptible to this first-pass metabolism, a large fraction of it might be destroyed or chemically altered before it ever reaches therapeutic levels in the main circulation.
Making it less effective, or maybe not effective at all orally.
Exactly. Parenteral administration bypasses this entire filtration process. This leads to much faster onset of action, higher bioavailability, meaning a greater percentage of the drug actually gets to where it needs to go,
Okay.
and generally more predictable dosing because you're not guessing how much the liver will take out.
So connecting delivery to action then, the physical form is the pharmacokinetic strategy. If you need a systemic, rapid effect, someone's in anaphylactic shock, you choose an injection.
Absolutely. A 4EV ideally.
But if you need slow, constant dosing over multiple days, maybe for chronic pain, you choose a transdermal patch.
Makes sense.
The container, the form, is just as important as the chemical inside it.
It really is. Form dictates function here.
Okay, here's where it gets really interesting. We are moving from the name and the form to the how, the fundamental interaction between the drug molecule and the cell, the biological interface.
This is the core vocabulary of receptors and responses, and it really defines the biological relationship.
It does. And almost every drug works by interacting with a specific target. Often, it's a receptor protein embedded in a cell membrane. Think of them like highly selective locks.
Locks on the cell surface.
Or sometimes inside the cell, yeah. But they're designed to be opened only by specific keys, specific molecules. So we have two primary relationship types that describe a drug's interaction with these receptors, the agonist and the antagonist. This is absolutely fundamental vocabulary in pharmacology.
Okay, let's elaborate on that lock and key analogy you mentioned.
Okay, so an agonist is like the perfect key. It's a drug that not only binds to the receptor, it also activates it. It turns the lock.
Triggering the response. Triggering or enhancing the intended biological response, yes. It mimics the body's own natural signal, what we call the endogenous ligand. It turns the lock fully.
Can you give an example?
Sure. Opioid pain medications are powerful agonists. They bind to opioid receptors in the brain and spinal cord, mimicking the body's natural endorphins, and that's what triggers the pain relief.
Okay, so that's the agonist, the key that works. Conversely, the antagonist. This also binds to the receptor.
Yes, it binds, often very tightly. But instead of turning the lock, it completely or partially blocks the activation.
It jams the keyhole.
It jams the keyhole, exactly. It fits well enough to get in and occupy the space, but it doesn't have the right shape, let's say, to actually turn the mechanism. And critically, it blocks the natural key or an agonist drug from getting in and causing an effect.
That distinction is incredibly powerful clinically, isn't it?
Oh, absolutely.
Yeah.
Antagonists are used all the time to block processes that are maybe running out of control. Well, naloxone is a famous antagonist. It's used to reverse opioid overdose. It literally kicks the opioid agonist off the receptor, jams the lock, and rapidly reverses the dangerous respiratory depression.
Wow.
Another very common example, beta blockers. These are antagonists that block adrenaline and noradrenaline from binding to beta receptors, particularly in the heart. This slows the heart rate, lowers blood pressure, very widely used.
Right. Building on that interaction, we can look at specific drug classes based on how they alter the nervous system. Our sources highlight two critical terms related to pain and sensation, which people often confuse. First, anesthetics.
Right. Anesthetics are agents that reversibly depress neuronal function. The key outcome here is a profound, usually generalized loss of ability to perceive pain and or other sensations.
And often coupled with loss of consciousness?
Often, yes, especially with general anesthetics. The effect is systemic, affecting the central nervous system primarily, and it absolutely must be reversible and highly controllable. You need to be able to turn it on and off precisely.
Okay. The functional counterpoint then is analgesics. These are drugs used to relieve pain, but without causing a loss of consciousness.
That's the fundamental difference. With analgesics, the patient remains aware, remains functional, while the pain signal itself is interrupted or somehow mitigated.
And they work differently.
Oh, very differently through varied mechanisms. A simple analgesic like acetaminophen seems to act centrally, maybe increasing the pain threshold in the brain. Others, like NSAIDs, non-steroidal anti-inflammatory drugs.
Like ibuprofen?
Exactly, like ibuprofen. They tend to act peripherally at the site of injury, reducing the production of chemicals like prostaglandins that transmit pain signals. So an anesthetic causes a sort of sensory blackout. An analgesic just manages the feeling of pain while you remain aware.
Okay, got it. And then we have drugs that specifically target the autonomic nervous system, the automatic functions, like anticholinergics.
Right. These are drugs that block the passage of impulses through the parasympathetic nerves.
Parasympathetic, that's the rest and digest system.
That's the one. So blocking it can have pretty profound clinical effects because you're essentially tipping the balance towards the fight or flight sympathetic system.
So what kinds of effects?
Well, they can reduce salivation, they can increase heart rate, relax the smooth muscles of the digestive tract or the bladder. They're used in everything from treating urinary incontinence or symptoms of IBS to drying up secretions before surgery or even dilating pupils for eye exams. Now let's connect these types of actions to major systemic health outcomes, particularly concerning the circulatory system, blood pressure, blood flow. Maintaining the right balance relies on a constant push and pull between two opposing forces acting on the blood vessels.
Okay, and those are the vasodilators and the vasoconstrictors. Sounds pretty straightforward.
It is, conceptually. Vasodilators are drugs that cause dilation of the blood vessels. They make the vessels wider,
How?
usually by relaxing the smooth muscle cells in the vessel walls. This fundamentally lowers the resistance against which the heart has to pump blood.
Ah, so it makes the heart's job easier.
Exactly, which reduces blood pressure. Nitroglycerin, for example, is a classic vasodilator used acutely to treat angina, that chest pain,
Right.
because it rapidly opens up the coronary arteries,
Yeah.
the ones supplying the heart muscle itself.
Okay. And the opposing force is vasoconstrictors. These cause constriction or narrowing of the blood vessels.
Right. This increases resistance, squeezes the vessels, and therefore often raises blood pressure.
When would you want to do that?
Well, vasoconstrictors are used systemically, perhaps, to treat certain types of shock, where blood pressure is dangerously low, or sometimes they're used locally, like being added to dental anesthetic injections,
there.
to constrict the local blood vessels, which keeps the anesthetic concentrated in that one area for longer and reduces bleeding.
Clever. Okay, so this push-pull is vital in managing conditions like hypertension, which our sources define as persistently high arterial blood pressure, specifically exceeding 140 millimeter Hg systolic and 90 millimeter Hg diastolic.
Right. And managing that chronic condition often requires a delicate long-term balance, frequently using vasodilators, but also sometimes other agents that manage blood volume.
Which brings us to...
Shifting focus slightly to the excretory system. Yes, we introduced diuretics. These are drugs that promote the excretion of urine,
Water pills.
commonly called water pills, yes. These are crucial in hypertension management as well, aren't they?
They are. By helping the kidneys remove excess water and sodium from the body via increased urine output, they reduce the overall fluid volume circulating in the blood vessels.
Less fluid, less pressure.
Less fluid, lower pressure. It directly reduces blood pressure.
Absolutely. And then for the digestive tract, another common class, laxatives, agents that simply promote evacuation of the bowel.
Usually by increasing water content in the stool or stimulating the muscles of the intestines, right?
Exactly, stimulating peristalsis, the wave-like contractions.
Well, our sources also introduce the concept of thromboembolic disorders. That sounds serious.
It is very serious. It involves the partial or complete obstruction of a blood vessel by a thrombus, a blood clot. This can lead to severe outcomes like stroke, heart attack, pulmonary embolism.
Depending on where the clot lodges.
Precisely. Pharmacological intervention here involves drugs used for antithrombotic disorders.
So drugs that fight clots.
Essentially, yes.
Okay.
But it's a complex class with different strategies. When we talk about antithrombotics, we're usually discussing three main types.
Okay.
First, you have antiplatelet drugs, like aspirin, that prevent platelets, the sticky little cells in blood, from clumping together to start a clot.
Right.
Second, you have anticoagulants, like heparin or warfarin. These interfere with the clotting cascade, the series of protein reactions that actually forms the fibrin clot. They basically make the blood less likely to clot.
Okay.
And third, you have thrombolytics. These are the real clot busters. They're designed to actively dissolve existing dangerous clots, usually used in emergency situations like during a heart attack or stroke.
3 different ways to tackle the problem.
Yes, it's all about preventing clots from forming or getting rid of them once they have to maintain that essential blood flow within the circulation. So if we connect this now to the bigger picture, understanding these mechanisms, these agonists, antagonists, vasodilators, antithrombotics, it allows us to define serious medical conditions and see clearly where these specific drugs are applied.
Right. Makes the conditions make more sense.
Exactly. Take the heart, for instance. A painful, often life-threatening condition is angina pectoris.
Which is defined as severe constricting pain in the chest, often radiating, typically to the shoulder and down the left arm.
And that pain is basically the heart muscle screaming because it's not getting enough oxygen.
Okay.
The underlying cause is usually ischemia, which means an obstruction or severe constriction of blood supply to the heart muscle itself.
So a blockage in the coronary arteries.
Usually. And that's why rapid pharmacological intervention, typically using those vasodilators like nitroglycerin we mentioned,
To open the vessels.
is essential to try and restore blood flow immediately and relieve that oxygen debt.
And the precursor, often, to many of these obstructive conditions is atherosclerosis, defined as a condition of thickening and hardening of the wall of a blood vessel,
Due to plaque buildup, yeah. Fatty deposits, inflammation.
which is frequently linked, in turn, to hyperlipidemia, elevations of plasma lipid concentration, high cholesterol, and triglycerides.
Right, so these three conditions, hyperlipidemia often leading to atherosclerosis, which then can lead to angina pectoris or even heart attack, they demonstrate a perfect cascade.
A chain reaction.
A chain reaction where pharmacologists use different tools at different stages.
Mm.
Cholesterol-lowering drugs like statins to manage the lipids.
Okay.
Antithrombotics like aspirin to prevent clots from forming on those rough plaques.
Right.
And vasodilators like nitroglycerin to treat the acute pain when flow is severely compromised, intervening at different points of the disease pathology.
Makes sense. We also need to mention neurologic diseases where chemical imbalances or deficits are often the primary target. For example, Parkinson's disease, PD, which is a degenerative neurologic disease of the brain, often impairs motor skills, speech, other functions. It's progressive.
And in Parkinson's disease, the core pathological failure is the death of specific neurons in the brain, neurons that produce the neurotransmitter dopamine.
So a chemical deficit.
A fundamental chemical deficit.
Yeah.
Therefore, the primary goal of pharmacology is often to try and restore that lost chemical signal. The most common approach is administering L-DOPA.
Which isn't dopamine itself.
No, dopamine itself can't easily cross the blood-brain barrier. L-DOPA is a precursor molecule that can get into the brain, and then the remaining neurons can convert it into dopamine.
Like giving the brain the raw materials.
Exactly. It essentially acts to boost the dopamine levels, working somewhat like an agonist strategy to help manage those progressive motor symptoms. the tremor, the stiffness, the slowness. It shows pharmacology isn't just treating symptoms sometimes. It's trying to provide the functional chemicals that the body itself can no longer produce sufficiently.
Okay, so we've covered the intended actions, the names, the delivery systems. Pretty complex, but logical. But the human body, as, highly evolved and generally predictable as it is, sometimes it just throws a curveball.
It definitely can. Which brings us to section 4, safety, reactions, and patient care. Because even with the most carefully calculated dose, the most targeted agonist, the body can react in a way nobody predicted.
Unintended consequences.
Exactly. This is where we delve into those non-normative responses, the failures of predictability, if you will. First up, the idiosyncratic reaction.
I find this concept both fascinating and, frankly, a bit frightening. It's a response that is not normative per its intended action or even its known side effects. It's unique to the individual.
It's the ultimate outlier. The ultimate failure of prediction, in a way. The drug works perfectly well or has predictable side effects for 99 people out of 100 or 999 out of 1,000.
Yeah.
And then for that one person, due perhaps to some unknown, maybe rare genetic variants in a metabolic enzyme or a receptor variant, it causes a completely unexpected, sometimes bizarre random effect.
Something totally off the wall.
Totally off the wall. It defies prediction based on the known chemical mechanisms or population data from clinical trials. It's really the bane of drug developers because it's practically impossible to screen for every single possible genetic variant in the entire human population.
Wow. Okay. Then there's the much more common, though potentially equally catastrophic, severe reaction, anaphylaxis.
Right. Anaphylaxis isn't idiosyncratic in the sense of being mechanistically weird. It's an extreme end of a known mechanism, the immune response. It's a condition of shock caused by hypersensitivity.
An allergic reaction gone wild.
Essentially, yes. An overexuberant systemic immune response to a drug or maybe another substance like a bee sting or certain foods. The result is life-threatening respiratory distress, often from airway swelling.
Can't breathe.
And vascular collapse, a sudden drastic drop in blood pressure.
Yeah.
This requires immediate emergency pharmacological intervention, usually a shot of epinephrine.
Adrenaline,
Yes. To rapidly reverse the swelling, constrict blood vessels, and counteract that massive immune system overreaction.
Okay. And lastly, on the topic of unexpected or longer-term effects, we must define physical dependence.
Right. Physical dependence is a physiological state of adaptation. The body has essentially incorporated the drug's presence into its normal functioning baseline. It's adjusted.
It's gotten used to it being there.
It's gotten used to it, yes. So if you suddenly remove that drug through abrupt cessation, maybe rapid dose reduction, or sometimes by administering an antagonist that blocks the drug's effect.
Like naloxone for opioids?
Exactly. The body then exhibits a withdrawal syndrome, a set of physiological symptoms that's usually specific to that class of drugs.
This is a really key distinction, isn't it? It's a physiological adaptation, not necessarily the same thing as addiction, which involves compulsive drug-seeking behavior.
That's a critical distinction, yes. Physical dependence is about the body's physical adaptation. Addiction is a more complex behavioral syndrome. But physical dependence demonstrates the profound systemic impact of long-term drug use. The body establishes a new chemical homeostasis, a new balance centered around the drug's presence.
And breaking that homeostasis causes measurable physiological disturbance, the withdrawal.
Precisely.
Yeah.
It really shows the incredible power of some drugs to alter fundamental physiology over time.
Okay. Moving to a practical application in patient care now, let's look at the continuum of sedation, often induced by anesthetic agents or other sedatives. This illustrates perfectly why studying pharmacokinetics and systemic effects is so critical, because the depth of consciousness can change rapidly and sometimes dangerously. Our sources define 4 progressive levels, moving from just barely relaxed to completely unconscious.
Yes, and these 4 levels are very strictly defined, primarily by the patient's ability to maintain their own airway, to keep breathing effectively, and their ability to respond to external stimuli, like voice or touch.
Okay.
And the clinical reality is that a patient can slide, sometimes quite quickly, between these states with only very small changes in drug concentration in the brain.
Which is why monitoring is key. So starting at the lightest level, minimal sedation, also called anxiolysis.
Right. Anxiolysis just means anxiety reduction. At this level, the patient is conscious. They are able to respond normally to verbal commands. They might be relaxed, perhaps a bit drowsy, but their protective reflexes like coughing or gagging and their cognitive function are essentially intact.
And breathing.
Ventilatory and cardiovascular functions are generally unaffected. They don't need any help to maintain their own airway.
Okay. Level 2, we move into moderate sedation analgesia, often called conscious sedation.
Yes, this is a state of depressed consciousness. Now, commands are usually responded to, but you might need a more stimulating touch or a louder voice to get that response.
So a bit harder to rouse.
A bit harder to rouse, yes. Coordination and cognitive function are definitely affected. But crucially, ventilatory function breathing is usually maintained without any intervention. Cardiovascular function is usually fine too. The patient is sleepy, needs monitoring, but can generally still keep themselves safe, breathe on their own, and follow basic instructions if stimulated.
Okay. The third level sounds like a significant jump in risk. Requires specialized staff. Deep sedation analgesia.
It is a significant jump. Here, consciousness is significantly depressed. Patients will only respond purposefully, meaning not just reflexively to painful stimuli, or maybe to repeated aggressive verbal commands.
So they're really out of it.
They're really out of it. And the real danger here is that their ability to maintain their own airway independently is often inadequate. Ventilatory function may be impaired.
Meaning they might need help breathing.
They might need airway support, like help keeping their tongue from obstructing the airway, or even assistance with breathing. Cardiovascular function might also be impaired, but usually remains adequate. This is a very thin, constantly shifting line between safe, deep sedation and, well, slipping into general anesthesia or respiratory compromise. Constant monitoring is essential.
And finally, the most profound and inherently most dangerous state, general anesthesia.
Right. This is a drug-induced state of total unconsciousness. Patients are completely unarousable, even to intensely painful stimuli. Ventilatory function is frequently inadequate, meaning the patient will likely stop breathing effectively on their own and require mechanical ventilation or manual assistance. And cardiovascular function may also be significantly impaired, often requiring pharmacological support, like drugs, to keep blood pressure up.
So total artificial support is often needed.
Total artificial support of breathing and circulation is usually necessary, yes. And the patient must be monitored constantly, minute by trained anesthesia professionals.
Highlighting the critical takeaway here, the depth of sedation is this continuum, and it's constantly monitored because a patient can slip, sometimes very quickly, from, say, moderate sedation into deep sedation or even overshoot into general anesthesia with very little warning.
That's right.
The margin for error is incredibly thin, which is why understanding the pharmacokinetics, how that particular drug is absorbed, distributed, metabolized in that particular patient, is absolutely essential to prevent them from sliding into ventilatory failure or cardiovascular collapse.
That potential for speed and unpredictability necessitates extremely careful dosing, using precise delivery forms like infusion pumps, and requiring the constant clinical vigilance that defines modern medical and anesthetic practice. So what does this all mean? Where have we landed after this deep dive?
Well,
I think we've successfully taken that stack of pretty complex sources, all those definitions, and gained, hopefully, a real fluency in the essential language of drug science.
I think so. You now know the difference between pharmacology, the study of the drug itself, and pharmacokinetics, that crucial time element, what the body does to the drug.
Right. You understand why a capsule works differently than, say, an IV injection. And you can clearly distinguish between an agonist, that key that works the lock, and an antagonist, the key that just jams it.
We also clarified the vital difference between anesthetics, which cause that loss of sensation and often consciousness, and analgesics, which just target pain. And we defined key concepts like vasoconstrictors and vasodilators, the things that squeeze or relax blood vessels, which is critical knowledge when you hear discussions about hypertension or angina pectoris.
Absolutely. And knowing those 4 progressive stages of sedation, from minimal to general anesthesia, it really underscores the seriousness and the precision required in any clinical intervention involving these powerful agents.
We started this deep dive way back at the beginning with Paracelsus's profound idea. It depends only upon the dose whether a poison is poison or not.
A lot kills, little cures.
We know that pharmacologists spend decades, billions of dollars, perfecting that curing dose based on kinetics, receptor binding studies, huge population data sets.
An immense amount of work goes into finding that therapeutic window.
And considering the definitions we covered for idiosyncratic reaction, that completely unpredictable, unique response.
The curveball.
And the potentially catastrophic risk of anaphylaxis, that massive allergic overreaction.
It does raise an important final question, doesn't it? For you, the learner. to maybe consider.
Yeah.
We always focus rightly on the intended dose, the drug, the target. But considering these inherent limitations, these unpredictable individual responses, what unexpected variable entirely unique to you, to your individual biology, is perhaps the hardest factor for pharmacologists to truly account for when they're determining that safe dose for everyone?
It's got to be that unique personal factor, doesn't it?
It's arguably your unique genetic blueprint. The subtle variations in your metabolic enzymes, the specific structure of your cell receptors, the hair trigger settings of your individual immune system. These are the deeply personal factors that create those unpredictable outliers.
A deep dive into a complex, sometimes unpredictable, but utterly life-saving world. Thank you for joining us.